Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the non-specific ulcers. Ulcers are the discontinuation of the epithelial surface. There is usually progressive destruction of surface tissues cell by cell, as different from the gangrene and necrosis. Ulcers are classified into non-specific, specific and malignant ulcers. Here we will discuss about the non-specific ulcers. Non-specific ulcers are due to infection of wound, physical or chemical agents, local irritation as in dental ulcer, or interference with the circulation like varicose veins. Clinical examination of an ulcer. It is discussed to identify the type of ulcer by the reader. Examination is conducted in a systemic manner. Site. Majority of the rodent ulcers occur on the upper part of the face. Carcinoma usually affects the lower lip and the primary chancre is on the upper lip. Size. Carcinoma extends rapidly than rodent ulcer and slower than the inflammatory ulcer. Shape. A rodent ulcer remains circular until a large size than a carcinoma. A gummatous ulcer is typically circular or serpiginous due to fusion of multiple circles. An ulcer of square area or straight edge is suggestive of dermatitis artifacta. Edge. The healing non-specific ulcer has shelving edge. It is undermined and bluish in tuberculous ulcers. Vertically punched out in case of syphilitic ulcer. Rolled or rampart in case of rodent ulcer. Raised and everted in case of epithelioma. Flow. The floor is the one which is seen by the observer and may be watery apple jelly granulation in tuberculous ulcer. A wash leather slough in gummatous ulcer. Base. The base is the area which is palpated. It may be indurated as in carcinoma or primary chancre. It is attached to the deep structures like varicose ulcer to the tibia. Discharge. Active infection is indicated by purulent discharge. If the discharge is blue-green, suggests the infection with Pseudomonas pyocyneus. If the discharge is watery, it is typical of tuberculosis. If it is blood-stained, it is in the extension phase of the non-specific ulcer. Bacteriological examination may reveal colonization by the coagulase positive staphylococcus. Spirochetes are found in the primary chancre. Lymph nodes. In rodent ulcer, the lymph nodes are not enlarged but may be enlarged in case of secondary infection. May be enlarged hard and even fixed in case of carcinoma. The inguinal lymph nodes draining a syphilitic chancre of the penis are firm and shooty. The submandibular nodes draining the chancre of the lip are greatly enlarged. Pain. The non-specific ulcers in the extension and transition stages are painful. Syphilitic ulcers are usually painless except anal chancre. Tuberculous ulcer very tough, though that of the tongue are painful. General examination. Evidence of debility, cardiac failure, anemia, or diabetes must be sought. A comatous ulcer may be associated with other stigmata like chronic superficial glossitis. Pathological examination. Biopsy confirms the carcinoma. Wassermann reaction test for syphilis and Montauk's test confirms the tuberculosis. The history of an ulcer consists of 3 phases as extension phase, transition phase and repair phase. During the stage of extension, the floor is covered with exudate and slough while the base is indurated. The edge is sharply defined and the discharge is purulent and even blood stained. The transition stage is occupied in preparing for healing. The floor becomes clear, the slough separates, induration of the base diminishes and the discharge becomes more serous. Small reddish areas of granulation tissue appear on the floor and these link up till the whole surface is covered. The storage of repair consists of the transformation of granulation to fibrous tissue which gradually contracts to form a scar. The edge of the ulcer becomes more shriveling and epithelium gradually extends from it to cover the floor. This healing edge consists of 3 zones: the outer zone of epithelium which appears white, the middle one bluish in color where granulation tissue is covered by a few layers of epithelium, and the inner reddish zone of granulation tissue covered by a single layer of epithelium cells. Trophic ulcer. These are caused by the impairment of the nutrition which normally depends upon the adequate blood supply and a properly functioning nerve supply. Ischemia and anesthesia will therefore cause these ulcers. Ulcers of the tip of the fingers occur in chronic vasospasm like Raynaud's disease and in syringomyelia. In the leg, ischemic ulcers occur around the ankle or on the dorsum of the foot. They are painful and resist local treatment. Ulcers due to anesthesia like diabetic neuropathy, spina bifida, tabs dorsalis, leprosy or a peripheral nerve injury are often called perforating ulcers. Starting from a corn or a bunion, they penetrate the foot and suppuration may involve the bones and joints and spread along the facial planes upwards, involving even the cough. Treatment. In addition to general treatment, the underlying cause like diabetes, arterial disease, a lesion of lotion and non-adhesive applications are used to aid the suppression of slough, hazen, granulation and stimulate epithelialization of non-specific ulcers of the skin. Hydrochloride solution, use of and 0.5% silver nitrate are popular in early stages, 0.1% zinc sulfate solution later. Local insulin 2 to 3 ml of 20 units per ml floated on the ulcer and dried in a current of oxygen indicated through a funnel is also popular. Other applications include paraffin gauze ointment incorporating zinc oxide and 1% hydrocortisone cream and silver foil. Household vinegar 1:6 is efficacious against pyosinus. Excessive granulation, commonly known as proud flush, need to be discouraged by excision, curettage or by application of a caustic as silver nitrate. Chronic or indolent ulcers often respond to infrared radiation, shortwave therapy, or ultraviolet light. Large ulcers in the healing phase are covered by a free split skin graft as soon as granulations are healthy. Healthy granulations are flat below the level of the surrounding skin, pink in color, and do not discharge pus. In order to make the excess granulations healthy, they should be excised, curated, or cauterized, and firm wet dressings are applied for hourly to keep them flat. Antibiotics and supportive therapy are given based on the investigations and type of ulcers. That's all about the ulcers, and in the next video I'll discuss about some other disease. Thank you.